So, ladies and gentlemen, this is Wang Yang from China. Welcome to our Young IFSO session, and thank you for staying till the last day, last session. And today I would like to, I'm very happy to introduce you our moderators. One is Sonia from Italy, who is our local host, and Daniel Morris from Austria, who is our president-elect. They will moderate for the rest of our program. So thank you again.
I would like to introduce the first speaker, the president of Young IFSO, Wang Yang from China, and he will talk about the 10th anniversary and the future perspectives of Young IFSO.
Wait.
Can we have the first presentation?
Okay, and today I would like to share a brief report, actually which I presented already in the IFSO General Council meeting. I will give you a very brief introduction about Young IFSO and what we have done in the past 1 year and what we are going to do in the coming year. So, and I hope after my presentation, more and more of us will join our team and join the Young IFSO. I'm Dr. Yang from the Department of Metabolic and Bariatric Surgery from the First Electric Hospital in Guangzhou, China. It's one of the largest city in mainland China, so if you have chance, you're welcome to our city as well. So today I would like to share you the structures, activities, some selected publication from Young IFSO members, and also our future plans. So as we are celebrating our 10th anniversary, and we got a new dynamic logo, which designed by our designer in the IFSO, and I already uploaded it to the Young IFSO Facebook page. You can download it if you need. And you can see this is our web page, which we just set up last year. And you can find our information there at the ifso.com. You can see a session, Young IFSO, on the web page. And this is our Facebook page. Now we got 1,200 subscribers. You can find our information, also the activities updates there. And recently we got our new Twitter account and also LinkedIn account as well. And these are the benefits of being Young IFSO members. So I'm not going to detail, but actually you can get a lot of connection to encourage more global collaborations, not only in clinical practice, but also in research as well. So you can read it from our webpage. So if you haven't filled in this survey, you can just fill in by your names, your emails, and we can put your names in our database. So far, we got 432 members who is under age of 45. So if you are senior, try to encourage your young colleagues to join us. And I would like to introduce you our board members, committees, and advisory board. I would like to especially thank a lot to our team. Without them, we can do nothing in the past 1 year. So I'm the president. Our president-elect is Morris, and immediate past president was Ian from Turkey, and our secretary treasurer is Renin from Malaysia. We also got 5 chapter representatives, like ABC chapter, Shahar, European chapter is Rosanna, and Latin American chapter Eduardo, and Managed chapter is Tema, and North American chapter is Togov. We also got 2 committees. Our scientific committee chair is Sonia on the stage, and communication committee chair is Daniel Gore. And our past president will automatically become our advisory board members, like Ian, Alexander, Capri, and Sylvia. So, and in the coming future, we would like to recruit more members on board and to really participate and organize an activity for the Young IFSO. So welcome to join us as well. These are the pictures of our chapter representatives. You can see Shahar, Hosanna, and Doris, Tema, and Togov. And you can see a gorgeous Sonia and Daniel there. And maybe in the future, we can set up more new committees as well. Depends on our function or our future activity of the Young IFSO. So if you have any proposal, just contact any of us, and we can make you on board. And this is our past presidents, who is our advisory board members. And here I would like to briefly report to the activities we did it last year. The regular one is the Young IFSO Journal Club meeting. I think some of us may already attend the meetings before. For this meeting, we have two sessions. Session one is we invite some well-known experts like our like Professor Scott Shkora. They will share their experience not only in clinical practice but also in some scientific research, so we can learn from their experience. And session two will be for our Young IFSO members. They will share their latest data or latest publication as well. And luckily, most of our presentations in these meetings, they already convert their data into published paper. So this is quite encouraging. And we also got a Young IFSO session in different conferences. For example, IFSO APC meeting and IFSO European Chapter Congress, and also in some other national conferences, like in Germany, in Iran, ISMBS conference, in India, the OSCE conference, and Pakistan, the PSMBS annual conference, and other countries like Azerbaijan, Uzbekistan, and Pakistan, and Turkey, and other Central Asian countries as well, and of course in China too. And these are some of the pictures in the conference, and some active members also involved a lot, like Tao from Azerbaijan, and he also encouraged the members to participate in Young IFSO activity as well. So, and some of our members also actively participate in their national society, like ASMBS and other national society as well. And of course, like today, we got a Young IFSO session in the World Congress as well. And this year, I think this session is the only session that we accept abstract submission, because all the abstracts are not invited speakers. They are submit your abstract, and then our scientific committee will evaluate the abstracts and choose 7 abstracts for this session. And 2 of them accepted as the top papers. So the organizing committee just moved them to the top paper session. And here are some of our selected publications last year by our members. First one is Morris did a very good job. He wrote a spotlight, which published in the British Times, to introduce Young IFSO and our plans in the future. You can also read it from the magazine. And another one is the global survey, which we just collected 214 respondents from 61 countries or regions. This is very important data, which can be a good reference for our future training and education. Morris will introduce it in the next talk. And I already see many presentations from other rooms call our study, this study too, already. So there are some members won different awards in different conferences. For example, these 2 won first and second prize in the IFSO European Chapter meeting, and best paper and best video award in the Journal of Obesity Surgery as well. And many other papers actually published by Young IFSO members. Roughly, we may have more than 100 publications last year from our Young IFSO members. So maybe in the future, we can set up sort of a scientific library to share publication by our young members. So here are some of our future plans. I just made it up for 4 E's. One is expansion. We hope to expand our committee, hope to have more our young colleagues join us, not just few of us. And other E is education, so we can give more opportunity for each of us to learn from each other and share and collaborate with each other. Another one is, I think, is the most important thing, is the evidence. As we know, data is the king, right? We need evidence-based data, so we maybe we can conduct more multinational studies or multi-center studies for this. And equity is try to be more practical to beneficial to most of our members, not just a small group of people. Okay, and this is probably my last few slides. These are the planned future activities. Maybe you can have it on our Facebook page and other social media platform. And just like this one, Animal Lab for Young Surgeons, which is hosted by Sonia, will be happening again here in Naples, in Italy. So if you got time or you are interested, please scan the QR code and register. And some of our members, they are hospital or they are university, they offer some offership opportunities or observership as well. So if you want this, you can contact any of us. And this is my last slide and about the research project. So in another room, we're talking about around a certain percentage of the abstracts, they didn't turn it into published paper. So I hope we got 7 abstracts, right? So I hope you can submit your abstract, make it a full paper and submit to any of the journals and get it published in the near future. And we also welcome any research idea, and we will try our best and to make it global collaborations and make it happen and make it published. So I just presented you the structures, activities, related publication, our little future plans. So I hope you can, if you are senior, please ask your junior to join us, join our Young IFSO. And for those who haven't signed your name on our survey, please do it through this webpage. So I thank you again and for coming here to join us, and also thank you Morris and Sonia for moderating for the rest of the presentations. Thank you very much.
Thank you, Wa, for this nice overview. Are there any questions? Okay. Can you maybe say in 2 or 3 more sentences what are really the advantages of people, of young surgeons to join Young IFSO? Can you maybe say in 2 or 3 sentences what's the advantages for young surgeons to join Young IFSO?
In my opinion, I think it's the connection. We have a very great platform. We can connect you internationally, no matter for your clinical practice or research project as well. So we can provide this opportunity and help you to make your dreams come true.
Thank you.
Thank you.
Thank you, Wa. I think it's really an invitation for all of you who wants to be active, who wants to do studies, who want to join us. We are young, we are open, and yeah, you know, sometimes it's difficult to ask the senior professor for help, for scientific help, for surgical help. And I think, yeah, we are the future, and we have to get better, we have to evolve. So it's really an invitation. When you want to, we are here, and we help you. Yeah. Okay, so it's my pleasure now to present Daniel Felsenreich. He works with the actual president, Gerhard Braga, and he's our president-elect, and yeah, he will present the Young IFSO Bariatric Metabolic Surgery Training and Education Survey, which we have performed and which was published this year. So Moritz, it's your turn.
Yeah, thank you very much for having this talk here, and I'm very proud to present this first study published by Young IFSO in obesity surgery, and it's a project of the whole executive board of Young IFSO, and yeah, I will present it here. So it's a survey about bariatric and metabolic surgical training and education. I have nothing to disclose. So this is the publication. If you want to read it in detail, you can go to this paper. There over 50 questions that were asked in this survey, and I will go only through of them. So the aim of this international study of this survey was to find variations and trends in bariatric and metabolic surgical training, and this survey may also help to standardize and improve the bariatric metabolic surgical training in the future. The participants were young bariatric and metabolic surgeons up to an age of 45, and mainly these were young IFSO members, but also others that are connected to metabolic and bariatric surgery. We had a 3-month survey period between December 2022 and February 2023, and in total, as I told already, these 50 multiple choice questions. And they consisted of socio-economic, socio-democratic data, training background, bariatric surgical experience, scientific participation, current work position, and also the surgeon's case load, the current surgeon's case load. In total, we had 240 participants in this survey in 61 countries all over the world. 80% of these participants were male, only 20% female. The mean age at the time of the survey was 37 years, and most of them were already consultants, so metabolic surgeons below 45, but not residents anymore, and the second group were trainees and residents. Also interesting, the mean age when they performed their first bariatric procedure was quite high, with 31.5 years. This is where these participants of the survey are coming from. These were quite equal to private, public, and university setting, 27, 30, and 25%. On the right side, you see the year when the surgical when the residents performed their first laparoscopic surgery, and this was in most of the cases, as you see here, no, I cannot point, in the first year. But in terms of bariatric and metabolic surgery, if you see it globally, then most surgeons have not performed even one procedure within the residency time of the 6 years residency. Some of them had some cases in the first, second, and third year. And if the participants were asked which was the first step or the first part of the operation they were allowed to perform, it was parts of the sleeve gastrectomy, the majority preparation of the stomach during the sleeve gastrectomy, and then on the second place stapling the sleeve. And if we go in detail now, the bariatric procedure during the residency, as you see here in the first line, if you look at all bariatric procedures, 30% of the residents don't do any bariatric procedure within their residency, and then there are a few that are doing, this is the second group, that are doing 1 to 50 procedures within this 6-year period. And if you go into detail, for example, for the sleeve gastrectomy or the Roux-en-Y gastric bypass, also 33% don't do any procedure during the residency, or in terms of the gastric bypass, over 50% don't do any procedure within the residency, but then some of them are doing 1 to 50 procedures within this period. The same for the revisional procedures. This isn't done by residents in over 66%, and endoscopic bariatric procedures is not performed by residents up to 84% here. There are also some other interesting questions that I want to mention here. For example, when they were asked about, is it mandatory in your country to perform a surgical training, cadaver courses, animal courses? 80% say it's not mandatory to do bariatric surgical procedures. Only 20% said it's mandatory there. Are you challenged to perform scientific presentations at international and national congresses? Over 60% said yes, it's mandatory, and this is an interesting fact because, as we have seen before, only 25 are coming from a university hospital setting, so it seems that also in the private or in the public hospital setting, bariatric surgeons were forced or were able to do some scientific workup. So I cannot. Okay. The same here. Do you have a scientific mentor? Yes, in over 50%. Even only 25% are in a university hospital setting. Can I go back to the conclusion? I'm missing my last slide, my last two slides. One before. Yeah, here's the conclusion of this international survey. So what we have seen is that this survey underlines the lack of a global surgical curriculum in bariatric metabolic surgery during the residency time. For example, in Austria, the residents starting from the first or second year to do some sleeve gastrectomies, or also to suturing the tracheostomy, but globally this is a little bit different. And it also shows that the sleeve gastrectomy and its surgical steps are the single and most performed procedure by young surgeons, and highlights also the role as a teaching tool already in the residency time. Further, this data might underline also the importance of advanced surgical education and further research in this topic. Thank you for your attention. As I introduced already, this is the executive board of Young IFSO, and I'm happy also to announce the next European Chapter Congress of IFSO is in Vienna, and we will also have a Young IFSO session there with a competition for the best talk and so on. So I hope many of you can come to Vienna in May to participate this Young IFSO session there. Thank you.
Thank you, Moritz. Do you have questions? I think the most important thing of this survey was to show, and to show also big if so, that we should improve education, surgical education and scientific education. And this is the project we want to perform in the future. And as you said, at IFSO Vienna we have best prizes. And so we invite you really to submit abstracts and to come to talk.
Yeah, and I also think it's very important to see that there's so much difference when the education of bariatric and metabolic surgical training starts, and I think it can start earlier than after the residency time, in my opinion.
It has to.
Thank you.
Okay, thank you. So I now want to introduce the first speaker from Iran. No?
There's actually been a change, so they may have it for the...
Okay, so now who's... You're Geoffrey Cho?
Correct.
Okay, great. And you're talking about?
So I'm going to be talking about some of our outcomes from bariatric surgery and related to some of the Oklahoma data that we have. So I would like to mention that thanks to the moderators and the Congress for the opportunity to present our work. Dr. Fatahi was one of our collaborators, but unfortunately she was not able to make it. So I was here presenting some of our other things, so I fortunately was able to present this. So if we could please project the slides. They're under Chow. Perfect. So again, the title of our work is Bariatric Surgery Improves Outcomes of Future Inpatient Admissions of Patients with Type 2 Diabetes Mellitus, an analysis of the hospital inpatient admissions in Oklahoma. And again, I'm Dr. Geoffrey Chow. I'm the director of our bariatric surgery program. But again, would also like to thank Dr. Fatahi, who is one of our collaborators, but was not able to be here just due to some travel issues. So these are my disclosures. This will not be relevant to this talk. So we know that type 2 diabetes mellitus is associated with obesity and lifestyle, and as some of us heard even earlier today, I think as we move to realize how obesity is a problem and a disease in and of itself, We also know that there are other social determinants of health and other factors that can play a role in the incidence and prevalence of both diabetes along with obesity. As we look at where we are in Oklahoma, Oklahoma is uniquely impacted by both these social determinants along with the incidence and prevalence of these diseases. Our obesity rates are actually very high, so 36, and I think in some of the newer data that will be released this year, up to even above 40%. And even within the United States, it's the third to fourth highest, with only West Virginia, Kentucky, and Alabama being higher. And we know that treatment of obesity can improve and cause resolution of diabetes mellitus. And as we know here, certainly bariatric surgery is the most effective treatment of obesity and is associated with upwards of up to 80% and higher resolution of diabetes mellitus in those patients. So the purpose of this project was to evaluate the impact of type 2 diabetes mellitus on hospital admission rates and utilization of inpatient services when they were required to be admitted. And we specifically also wanted to evaluate the impact of having had prior bariatric surgery on the hospital utilization, both in the rates of hospital utilization and the other inpatient services that were required when they were admitted. So what were our methods? We utilized the Oklahoma Inpatient Public Data Use File, which is managed by our Department of Health, and it captures near 100% of the inpatient facilities, so there's only 2 out of 141 that are not captured. And for this study, we looked at data from 2016 to 2019, and we categorized and stratified patients by those with diabetes compared to those without. And we also stratified based on the ICD diagnosis codes and procedure codes that were required for in the admission. And we looked at what was the primary reason for those patients being admitted. We also, with this data, were able to capture if somebody did have a history of bariatric surgery, so we could very well stratify, did somebody have bariatric surgery, or were they somebody who had one of these comorbidities and they had not had them. We did exclude some criteria, so if we excluded teens. We do have adolescent patients that do undergo bariatric surgery, but for the purpose of this, we wanted to exclude them. And also if there were data items that would have made it so that the data was not reliable. So if the charges were too low or if they had a length of stay that wasn't compatible with a stay. So what were the results? So 27% of the admissions, so just over 400,000 out of 1.5 million during this time period were in patients that had diabetes mellitus, so a significant burden on the healthcare system. The overall hospitalization rate for patients with diabetes was 330 per 1,000 compared to 125 in patients that were non-diabetic, so almost a threefold increase in the patients that had diabetes compared to those that did not. You can see those in the heat map that was depicted below. So certainly on the right, across all counties and all parts of the state, if you had diabetes, your risk of admission was significantly higher. So what was the hospitalization length in the patients with diabetes compared to those that did not? So if you did have diabetes, your average length of stay was 5.8 days versus 4.9, which was statistically significant. Along with that, the patients with diabetes had a statistically significant higher charge for that length of stay, so 56,000 versus 50,000. And again, you can see those depicted both below. Both the charges and the length of stay are both increased in the patients with diabetes. So also, if you look at the other comorbidities and conditions along with procedures that patients had to have when they were in the hospital, we found that the patients who were diabetic across the board had higher rates of multiple comorbidities. They had a higher rate of limb loss, acute kidney injury, higher rate of heart failure, myocardial infarction, limb amputation, higher rates of needing coronary artery bypass, along with even needing a central line during that admission. So all of these statistically significant that if they were a diabetic patient versus a non-diabetic, these rates were higher across all admissions. So what about when we look at bariatric surgery? So we saw that if you look at the patients who had bariatric surgery compared to those that did not have a history of bariatric surgery, across the board, the risk of having a limb loss, acute kidney injury, heart failure, CABG, central line, when you look at whether they were patients that were diabetic or not diabetic, all of those were statistically significant that if you had prior bariatric surgery, your chance of needing any of those for both the diabetic patients and non-diabetic patients was lower. So what's the relative risk when you look at those? So even if we look just at the chance for admission, so if a patient had a prior bariatric surgery, Their chance of being admitted to the hospital, their relative risk for that was decreased by 16%. Or if a patient did have diabetes, there was a 43% decrease in admissions if patients had diabetes as the primary admitting diagnosis. So for whether they're diabetic or non-diabetic, if you did have bariatric surgery, your chance of being admitted to the hospital was subsequently lower than if you had not had bariatric surgery in the past. Along with that, what's the chance of dying? So the risk of death during admission or having discharged to a hospice care had a relative risk of 0.29 in the diabetic patients who had a prior bariatric surgery. So along with some of the other data that we've seen, so if you have had bariatric surgery, for all-cause mortality and being discharged to a hospice was lower in patients who were diabetic if they had had prior bariatric surgery. And what about for non-diabetic patients? If the non-diabetic and had a prior bariatric surgery, their risk of admission also was reduced. Their relative risk was 0.9 for needing to be admitted compared to non-diabetic patients who did not have a prior bariatric surgery. So in conclusion, so type 2 diabetes mellitus across the board is associated with increased hospital utilization, length of stay, and hospital charges. For patients that do have type 2 diabetes mellitus, the risk of having multiple cardiovascular conditions along with procedures was increased compared to patients that did not. And these patients required more interventions when they were admitted. Across the board, bariatric surgery decreases the need for subsequent hospital admission. It improves comorbidities, and when these patients are admitted to the hospital, their need for interventions along with their cost and mortality are reduced compared to patients that have not had prior bariatric surgery. So again, thank you to the moderators, and apologies for the trouble getting the slides at the beginning, and I'd love to entertain any questions.
Thank you for this great presentation. Was there, or were you also be able to see some difference between surgical procedures, or do you just have the information that they had bariatric surgery or not?
Yeah, so with this data set, we capture if they have had prior bariatric surgery. It's not able to delineate which operation, so whether they've had a sleeve or they've had a bypass. In our institutional data, we are looking to see prospectively, how do these patients do? I can tell you from our case mix, we probably are at, my apologies for not having the slide, but we're at just about 50% of bypass. The other half is going to be a combination of sleeves, and we're about between 2 to 5% SADI at the moment.
Okay, so you have 50% bypasses in this cohort. Okay. Any other questions?
May I comment? As you have a very large sample size, maybe next time you can also develop a prediction model. For example, what kinds of patients under certain condition, they will have better type 2 diabetes remission after the surgery, maybe.
That's a great idea. We actually previously used this data set looking at a different population that had a predictive model, but we actually would love to work on that, and if anybody wants to collaborate, we would love to have the opportunity.
Great.
Yes?
Hi, Tolga Talashinsky from New Jersey. Thanks so much for your presentation. Two questions. One, in that data, were you able to capture the time from the bariatric surgery to the time you analyzed it? Like how many years did you have to see the effect since the bariatric surgery to improve in the life expectancy? And the second question is, in your diabetic patients, were they all morbidly obese, or it was all diabetics, period?
So for the first question with this data set, we're not able to capture the time lag from when it was. In this analysis, we are able to stratify based on BMI. In this interpretation of it, we didn't do that, but we certainly will include that for the paper. And so thank you for that.
Thank you.
Thank you very much. So I will introduce the next speaker from Iran, Mohammad Taghi Rasai. And he will speak about midterm follow-up report of single anastomosis sleeve yeonal bypass in the Middle Eastern population.
Yes, thank you for giving me this opportunity, and thank you again, Yang, as you said before, for selecting my paper as an eminent paper. I try to speak about single anastomose sleeve jejunal bypass. We call this sausage or sausage as a new method for treatment of obesity. Single anastomose sleeve ileal bypass, as you know, SASI, is a combined bariatric metabolic technique in which few studies have shown its outcome efficacy. However, this technique has a high risk of malnutrition due to a long biliopancreatic
Recording
limb.
in progress.
Sausage has a shorter limb, therefore it seems to have a low risk of nutrient deficiency. Furthermore, this technique is relatively new and little is known about the efficacy and safety of sausage. We aim to report our midterm follow-up of sausage, a high-volume center of bariatric metabolic surgery in Middle East region. For the current study, the 18 months follow-up of data of 43 patients with severe obesity who underwent sausage was collected. The primary outcome measures were demographic data, weight change variable according to ideal body mass index of 25 at 6, 12, and 18 months, laboratory assessment, remission of obesity-associated medical problems, and other potential bariatric metabolic complications after the surgery. As you know, over the time, bariatric metabolic surgery procedures develop into techniques with greater weight loss and fewer complications. A sleeve gastrectomy is one of the most prevalent and well-known approaches, which is one of the first choice for most patients with severe obesity and bariatric surgeons all around the world. Although a sleeve is surgically a restrictive procedure by decreasing the volume of the stomach, however, with an effect on gut hormones, decreased ghrelin, increased GLP-1 and increased peptide YY has a malabsorptive effect too. However, to create a more sustainable and significant weight loss anastomosis between the stomach and intestine or between two parts of intestine can be created similar to another well-known procedure like Roux-en-Y gastric bypass. An example of anastomosis between two parts of intestine beside a sleeve gastrectomy is between the duodenum and ileum, which is called SADI. Recently, surgeons use more developed techniques with single anastomosis between a sleeve and ileum, which is called SASI, and last one, which is called sausage. SASI bypass has several superiorities based on the previous study by Dr. Mahdi. In addition, sausage and SASI, unlike SADI, are easily reversible techniques. However, sausage is kind of the modification to SASI with a shorter biliopancreatic limb length. Therefore, it seems sausage has a lower risk of nutrient deficiency. The longer common limb lengths compared to SASI may avoid long-term nutritional complications. Therefore, sausage is safer theoretically and SASI in patients with extreme weight loss and baseline nutritional deficiencies and simpler due to surgical steps. Sausage is a newer bariatric metabolic technique, and the literature needs more investigation on its safety in all aspects and efficacy from around the world and in different techniques. Besides Suifi et al., who reported their experience with sausage in 2 and 6 year follow-ups on an acceptable number of population, this procedure is neither a common approach for surgeons nor patients due to its unknown outcomes and complications. Therefore, in this study, we aim to report our midterm follow-up of 18 months in bariatric and metabolic surgery in our centers. As I said before, 43 patients were collected in Al-Zahra University in Isfahan from January 2016 to April 2019. Due to being a new surgical approach and adhering to our local and national ethical consideration, large sample size was not feasible for this study. And the 2016 IFSO position statement and 2012 interdisciplinary European guideline metabolic and bariatric surgery and later amendments were used as surgical criteria. Patients aged between 20 and 60 years old with body mass index above 35 and with an obesity-related medical problems such as hypertension, type 2 diabetes, or BMI above 40, and patients' willingness to participate in this study were determined as an inclusion criteria. As long as this procedure is a new introduction for bariatric and metabolic surgery, those who were not candidates for other common techniques such Roux-en-Y, one anastomose, SADI, or SASI were selected for sausage. Next slide, please. Not working. Guys, exclusion criteria were those with previous bariatric metabolic surgery, heart failure, pregnancy, malignancy, rheumatology, and immune system problems, uncontrolled psychological disorder, or drug abuse or addiction. Patients were treated by the same multidisciplinary team constituting of the same surgeon, dietitian, psychologist, gastroenterologist, and radiologist. In brief, for intervention, a routine sleeve gastrectomy was done, and for the gastrojejunal anastomosis, 200 centimeters from trace ligament was measured, 40 times 5 centimeter by 5 centimeter by the fenestrated grasper. The intestinal loop was brought up to the gastric sleeve. A staple side-to-side anastomosis was performed using a 45 linear cutting stapler and at the side of the antrum, 4 to 6 centimeters far away from the pylorus sphincter, posterior to proximal part of the sleeve, stapling facing to the gastric fundus. And the entire stapler line was reinforced using 2 OPDS treat. The gastrojejunal anastomosis defects was closed with a 2-layer running suture, and methylene blue leak test was performed during the procedure to assess if there were any leak. And the post-operative care is like about another surgery for early embolization, post-operative thrombus prophylaxis, for starting liquid diet. And,
can you please show us the results, because
yes,
we have to
I try.
stay in
I
time.
try to say as fast as possible. And this is the demographic data that we collected. At the result, 43 patients, severe obesity, I said the mean age of 35 to 30, mean age of 35 years, and all at female gender predominance of 65%. The baseline height, weight, BMI, weight change related variables are assessed. As you can see here, BMI at the baseline was 45, and the 18 months after surgery, BMI is reduced to 28. Excess weight loss was 68, and total weight loss was 36. None of the patients presented major bariatric metabolic complication. Upper GI series revealed that the same amount of food passed both the antrum and GJ anastomosis in 6 out of 10 samples. However, in 2 of them, most of the foods passed the antrum, pylorus, duodenum pathway, and the remaining 2 samples showed the GJ anastomosis passed a higher amount of food. You can see in this table remission of type 2 diabetes, hypertension, hyperlipidemia, GERD, and vitamin D deficiency is significant after 18 months. And you can see in this figure excess weight loss and total weight loss for reducing weight for these patients. And in this table, you can see we find no adverse effect was seen in 61.5 of the patient. Nevertheless, hair loss, hemorrhoid caused nausea, and the most significant complaints in 12, 1, and 2 of the patient respectively. Hemoglobin at the baseline and 18 months, vitamin D, hemoglobin A1C, albumin, ferritin, vitamin D, and none.
Can you come to the conclusion? We are already double up the time.
Okay, I try to. As well, for discussion, we have, there's some papers before us comparing this study with another old study, and I want to say the differences between our study, and this is regarding efficacy of sausage on weight loss. Our patient reached the excess weight loss of 40, 54, 65, and 68 in 6, 12, and 18 months respectively. And we want to say, at least in the conclusion, this
last slide, please.
Yes, I tried to. For conclusion, we said sausage bariatric metabolic procedure has noticeable excessive weight loss, helps remission of obesity-associated medical problems, and improves little or no major complication, which all of them are similar to other well-known bariatric approaches. However, more investigation are needed on this subject in other parts of the world with longer and larger sample size. Okay.
Do you have questions, please?
Hi, Benji Pascotto from Luxembourg. Just one consideration, because at the end you compared SASI and SASJ. I think that's two completely different things, because SASI is a metabolic operation, SASJ is a bariatric operation. So SASI is more close to like SADIS, like duodenal switch, Santoro bipartition. The literature about the SASI is not so poor as you said at the beginning, because it's almost 7 years that the operation exists, and what is right, at least until now, is that with the 3 meters loop, there is no risk of malnutrition. So my question is, because for the indication for SASI for patient is the super obesity, most of all, like more than 50 of BMI. So what are the indication for SASJ? Because the patient that you put with a mean BMI of 44 are patients that I would choose more for bariatric surgeries like Roux-en-Y. So why SASJ?
I didn't have any time, unfortunately, because it is the inclusion criteria was in my slides. For example, your patient before endoscopy, before surgery, he has or she has intestinal metaplasia or a family history positive of gastric cancer, and he or she can include in our paper. Against his sweeter, what should we do? What kind of surgery is suitable for him? We thought that sausage could be helpful for him.
I think this is a young IFSO session, and it's of most importance that young IFSO surgeons start to learn the standard bariatric procedures, because worldwide we have to have standards, and we have also be able to give the right indication ethically. So obviously when it's part of an experimental design, you can perform it. It is important to be innovative, but for all of us, maybe the conclusion is do the standards and pay attention with new experimental studies. Yeah.
Thank you.
Okay.
Last question.
Sonia, it's exactly a comment I was going to make. Exactly a year ago, Dr. Cohen published an IFSO ethical guidelines in research. So I will definitely quote that paper. But congratulations on your study.
Thank you. Thank you very much.
So the next speaker is Matias Sosa from Argentina, initial experience of bariatric and metabolic centers, aged under 35. How old are you? And a multicentric study.
Good afternoon, everyone. Thank you, Chairman, for the introduction. The first spoiler alert is that I'm not longer 35, I'm 37, okay. But it will be explained in a few minutes. The second spoiler alert I would like to say prior to my presentation is that the objective of this study was not to polemize, to criticize any system, to challenge any experienced surgeon. It's rather to send a message to us, young bariatric surgeons, and to our bariatric community that is feasible if you have the right tools to become an acceptable bariatric surgeon. Right? Well, as the title says, I'm Matias Sosa from Argentina. First of all, although bariatric and metabolic surgery has been arised more than 50 years ago, the surgical technique, skills acquisition, and learning curve have always been a subject of debate. The first study I found emerged in early 2000s, basically talking about learning curve, its length, if it increases mortality and morbidity rates, apparently it didn't. They didn't, because when a center incorporates fellowship programs, it becomes more formal with more protocolar. So morbidity and mortality rates gets lower. As you mentioned before, in your survey you published a few months ago, here is a key to understand how a bariatric and metabolic surgeon can acquire his or her skills. For example, in my personal case, I didn't start preparing a sleeve in the center where I made the fellowship. I started doing around sutures on the excluded stomach, and then prepared for the sleeve, just to gain surgical skills. And obviously, my center was more inclined to gastric bypass rather than sleeve. So once we finished our residency program and we want to go or meet or achieve that experience of a more aged surgeon, we need a process step by step. It could be simulation in dry lab, it could be a postgraduate courses like here, observer or fellowships program. But our objective with this presentation is to identify or to demonstrate if it is possible to achieve acceptable morbid mortality rates as a young bariatric surgeons. And the objective is to demonstrate our non-inferiority to other published data. As the slide before, all of us are under 35. The inclusion criteria, the patients who underwent must be in primary bariatric surgery from September, almost 2 years. We were 6 bariatric centers, all of us with university accreditation program fellowships, and all procedures must be performed by primary surgeons aged under 35. Revisional surgeries were excluded, and we assessed operative time, 30-day complication rate, and hospitality stay. The main reason we performed this study was to be presented in IFSO Miami 2020. But as you all know, things happened, and COVID pandemic happened. And so we take this work and bring it here now with a different age. This is my country, Argentina. There were 6 recruiting centers. All of us were formed or have made our fellowship program in 2 big cities: Buenos Aires, the biggest, and Córdoba, the second biggest city in Argentina. We were 2 bariatric centers where I belong to, and there another one in the northern part of the country, another one in the center, another one, the last one, in Buenos Aires. The total of patients we recruited in those 2 years were 308 patients. This is how it was divided. The operative time we got in this study was 97.6 minutes. Obviously, there was a difference between surgical gastric sleeve and Roux-en-Y gastric bypass, almost double the Roux-en-Y. The hospital stay was 30 hours. Nowadays, in difference, we have 50% of our patients at least ambulatory, so just or overnight, but shorter than 24 hours. We can achieve this one overnight discharge in 93.5% of our population. We have readmissions, 8 patients, 3 for nausea and vomiting in both sleeve and gastric bypass, 1 GI bleeding in gastric bypass. We manage with non-operative treatment, and we need to operate for another patient, 2 sleeve leaks with how do you say, laparoscopically toilet, and one hemoperitoneum in a sleeve gastrectomy, and one unaverted small bowel perforation in Rouen-Y. No other complication nor mortality were reported or registered in our series. As I mentioned before, these 4 needed to re-exploration. To conclude, initiation is hard. To decide which fellowship program you should apply is even harder. The objective of fellowships programs should be to the young surgeon to achieve his or her independency, so he can be independent and operate with another colleague, but not dependent on more experienced surgeon, in our opinion. Search accredited institution by university should be mandatory when we are searching for our skill acquisition and academic development. And the objective of this study, as I mentioned before, was not to challenge anyone, experienced surgeon. It was to demonstrate that young leadership and entrepreneurship is possible if you have not, it's possible potentially. No, it's possibly potentially. That's right. Sorry, my English. I'm nervous. And, well, this is us, all of the reps from Argentina, from Córdoba, Buenos Aires, and other cities. And this is our team from my team that's called CITOS, and you can follow us on social media. That would be all. Thank you.
Congratulations.
Thanks.
This is really important. I have to say, I also push young surgeons, but an important question. Who managed the 2 leagues? You or a senior?
No, me.
You,
because
okay.
I am, when we, with my partner, we established there were our leagues, we manage, we are surgeon, he's 1 year older than me, and when we had those 2 leagues, we operated ourselves, because we are like the CEO founders of our bariatric team. We made the fellowship program in different institutions, me in Córdoba and my partner in Buenos Aires. We became partners in another city, smaller cities. We are, obviously we are under, we have the support of other institutions like mentorship and something like that, but we can manage our patients. In fact, all of the complications we have, we manage them.
But I think the most important thing is not the age, but the numbers of bariatric surgeries you have performed before.
That's an actual and a key point. Perhaps I didn't demonstrate enough. In our fellowship program, the one I made, it's a 1-year fellowship program in Córdoba. It's a high volume center of 300 patients, and I perform myself as a primary surgeon 80 gastric bypass in all of its steps. Okay. And it obviously is not the first one I made it completely, but I started, as I said before, with a running suture of an extremely non-dangerous area, and then I moved forward to more accomplished, to more complicated or difficult tasks.
Okay. And have you also compared your data with your senior?
Sorry?
Have you also compared your data with your senior?
I did with ex-bosses.
Okay.
No, I didn't, because it would be...
Try it. You will be surprised.
It would be rude also. It could be rude also.
So thank you very much.
Thank you all.
And I will introduce the next speaker from Austria, Alexandra Szewczak, and she will speak about the preliminary results on a single center experience of 3 years Roux-en-Y gastric bypass in patients with gastroesophageal reflux disease.
Thank you for the introduction. Hello, everybody. Well, so as Moritz mentioned, that's the topic of my presentation today. These are my disclosures. And we looked at 3 years of patients with GERD who underwent laparoscopic Roux-en-Y gastric bypass, either as a primary or as a secondary procedure. And a short overview. So GERD has a worldwide prevalence of about 20% and has been rising for the past years, for the past decades. The statistics for obesity are similar, so how are both of these linked together? Well, obesity is one of the known risk factors for GERD, which is a multifactorial disease. And obesity can lead to an altered lower esophageal sphincter function, a decreased LES pressure. It can also lead to an increased intra-abdominal pressure and also occurs with a higher presence of hiatal hernia, and that is why both of these can be linked together. In literature has shown that the prevalence of GERD is linked with obesity up to 70%. And obese individuals have a 2.5 times higher risk of developing reflux and erosive gastritis in the course of their lifetime. So how can the laparoscopic, or as in our case laparoscopic, but the Roux-en-Y gastric bypass cut into it? So of course through weight loss primarily, but also through a reduction of this intra-abdominal pressure, and also through the prevention of bile reflux, which can be a late complication, for example, of a sleeve gastrectomy. And our objective was to assess the short-term outcomes and postoperative complications for patients with GERD undergoing laparoscopic Roux-en-Y gastric bypass as a primary or secondary procedure. And this was a single-center retrospective analysis, and we included patients with GERD as their primary diagnosis with either a BMI of 35 to 40 or previous bariatric interventions. The patients collected were operated on between March 2019 and March 2022. And our primary endpoint at this point was to assess the 30-day postoperative complications. We also analyzed the basic demographics, the BMI, the medical history, the gastroscopic, and all in all, preoperative evaluation, and also the reflux scores. As for our results, we looked at a total of 48 patients, 35 of which received Roux-en-Y gastric bypass as a primary procedure, 13 as a secondary. And of these 13 patients, 10 had had a gastric sleeve before, so a sleeve gastrectomy. One patient had a gastric banding, and 2 patients had a JG-2. And looking at the complications all in all, we had a 25% complication rate, so these were a total of 12 patients, 6 in the primary and 6 in the secondary group. Here's a table with our baseline characteristics. So we looked at all the parameters and we're looking for statistical significant differences. And what we found is that, as is also described in literature with other procedures, that the operation time was significantly longer in the secondary bypass group, and also that the complication rate was significantly higher in patients which have been operated on before. Other than that, the other data were quite comparable with what is published. So most patients were female with a mean BMI of 36.2. The length of stay was not different for both groups, so we then looked a bit closer at these complications. And as you can see, the types of complications in the secondary group is quite heterogeneous. So we had a GJ anastomotic stenosis, a JJ anastomotic stenosis, intraluminal bleeding, a perforation in the alimentary limb, also one case of regurgitation and an anastomotic ulcer. But what we also found is that of these complications, 4 were categorized as major complications, according to Clavend and Doe as 3B, and these patients had to be reoperated on. So to summarize, We had a total of 48 patients, 13 of which had a secondary procedure. The pH impedance was performed in 30 patients, so a total of 63% preoperatively, and the mean Demeester score was 22.7, so it was elevated. We performed preoperative gastroscopy in all patients, and this showed a hiatal hernia in 56% of those patients. The overall complication rate was 25%, with a total of 12 patients, and of these patients, 5 had had a revisional surgery afterwards, which is a total of 10%. And 4 of these patients were in the secondary group, and 1 patient was in the primary bypass group. And the complications that had to be operated on were 2 cases of JJ anastomotic stenosis, 1 intraluminal bleeding, 1 disperforation of the elementary limb, and also an incarcerated trochocyte hernia. As shown before, the complication rate and the operation time was significantly higher in the secondary bypass group, and we had no 30-day mortalities postoperatively. So to conclude, the laparoscopic Roux-en-Y gastric bypass is a safe procedure for patients with obesity and GERD. However, previous bariatric interventions can lead to an increased rate of complications and thus subsequent interventions. And we would like to point out the importance of routine upper GI endoscopic assessment prior to any kind of bariatric procedure in order to then choose the best kind of procedure for this patient, thus decreasing the risk of developing late complications, like, for example, GERD. And for our patient collective, we will need further data to assess the long-term reflux resolution rates. Thank you.
Thank you for the presentation, and I think it's great that you also have really measured data with the 24-hour pH-metry. I think this is very important, even this is a small cohort yet. Are there any questions? Yeah.
Hi. Very tall for me. I'm Ana Carolina from Brazil. This is congratulations on your presentation. Based on the title, I thought you were going to explore more detailed about the GERD relation to the complications. And as we've seen in other, during the Congress and on the literature, maybe detail more on the hiatal hernia, if you had tomography, or if you did hiatal hernia exploration during the procedure, because maybe if you associated hiatal hernia dissection to the Roux-en-Y gastric bypass, maybe this could be associated with greater complication rate or something like that. I didn't catch this information. Do you have it? Do you do associated procedures?
I don't have these. I don't have it on these slides, but most of the hiatal hernias we observed were small. So these were actually assessed during the endoscopy. And most of these were, I don't know the numbers by heart, but most of these were small, so we didn't do any CT scans or any other procedures for that as well. But of course, we will have to look further into this because these are just the preliminary results and yeah.
Thank you.
Thank you, congratulations.
Thank you.
We have to go on because we have 2 presentations left and only 15 minutes. So I want to invite Shindu from India to talk about a field study of postural ergonomics in bariatric surgery.
Minutes.
Good afternoon, everybody. I'm Dr. Sindhu, and I'm presenting my paper on a field study of postural ergonomics in bariatric surgery. I bring greetings from Bangalore Medical College and Victoria Hospital, which is situated in the state of Karnataka in South India. It is one of the top government institutions in the state of Karnataka. I would like to report that there is no conflict of interest to report. Work-related musculoskeletal disorders are injuries or disorders of the muscles, tendons, joints, cartilage or spinal discs, which are either caused by or made worse by the work environment. So as all of us would have experienced at some point during our laparoscopic careers, we would have experienced back pain, neck pain, or pain in the shoulders, elbows, wrists, or even some kind of discomfort. The incidence of this is reported to have been around 73 to 88% among laparoscopic surgeons. And laparoscopic surgeons have also reported career longevity fears and feelings of burnout as a result of the stress experienced. Why is this so? Why is this high prevalence of musculoskeletal disorders among laparoscopic surgeons? This is mainly because of the decreased degree of freedom of movement in laparoscopic surgery, the decoupling of the visual and the motor axis, the limited mobility of the instruments, and the recurrent instrument exchanges. Also, laparoscopic surgeons tend to assume an upright posture for prolonged periods of time, and also we tend to hold our hands in awkward positions such as elevated shoulders and abducted arms for prolonged postures. These add to the stress experienced by the surgeon. As we all know, the merger of the principles of laparoscopic surgery with the principles of bariatric surgery with the techniques of laparoscopic surgery has resulted in the treatment of surgical treatment of obesity being associated with shorter hospital stay and faster recovery for the patients. But the advantages for the surgeons are limited, and the difficulties faced by the surgeons are much more than what we face in conventional laparoscopic surgery. This is because of the increase in apparent height at which the surgeon operates because of the obese abdomen. And also in bariatric surgery, we tend to use longer instruments than we use in conventional laparoscopic surgery. As a result, the laparoscopic bariatric surgeon tends to hold his arms in a state of constant elevation and elevation of shoulders and abducted position of the arms, which causes a lot of stress to the muscles. And though there's a lot of research which is being done on ergonomics in conventional laparoscopic surgery, the literature limited or specific to bariatric surgery is very limited. So hence this study came to be. So the objective of this study was to assess the postural ergonomics of bariatric surgeons by using the REBA scoring system, which is the Rapid Entire Body Analysis Scoring System. This was a prospective observational study which was conducted in Victoria Hospital under Bangalore Medical College and Research Institute between the months of October 22 to March 23. So after obtaining consent, the bariatric surgeons were observed when performing 15 different bariatric surgeries, and awkward postures which were held for more than 30 seconds or repetitive postures which were being performed were captured in a high definition camera from the lateral and the posterior aspects. A small word about the REBA scoring system. This was developed by Sue Hynett and Lynn McCatamney in 2000. It analyzes the posture of the entire body, including the upper limb, the trunk, neck, and the lower extremities. Its advantages are its cost effectiveness, ease of use, and its ability to assess the posture of the entire body. This is how we assess by using the REBA scoring system. For the trunk and the neck, we look for the degree of flexion or extension, and also for the shoulders, elbows, and the wrist, we look for the degree of flexion or extension. And also in the trunk and neck, we look for any lateral bending or sideways bending. And in the lower limbs, we look for equal weight distribution across both the legs, and also whether the knees are held in flexion or extension. Based on this, we define the neutral position to be that of an upright trunk and neck posture with arms by the side of the body, elbows in 60 to 100 degree flexion, and wrist held in extension, and equal weight bearing on both legs and knees in complete extension. Based on this, we calculated the angles relevant for REBA scoring system as we can see in the figure. And REBA scoring system identifies 5 levels of risk ranging from negligible, low, medium, high, and very high. And based on the scores obtained, we categorized the surgeons into these risk levels. Statistical analysis was done using SPSS 23 software, and descriptive statistics were used to describe the data. And the REBA scores obtained were correlated with the BMI of the patient using a Pearson's correlation coefficient. So the BMI of the patients upon which we operated upon was ranging from 30.3 to 60 with a mean of 43.4. The REBA scores which we obtained ranged from 3 to 6 with a mean of 4.6 and a standard deviation of 1.08. We found that 80% of the surgeons came under a medium risk category for musculoskeletal injuries, and only 3% came under the low risk category. On comparison of individual postures, we saw that maximum deviation from the neutral posture was noted in the trunk and neck, with 80% deviation noted, and followed by the wrist and elbows and forearms, and all the surgeons maintained a neutral posture with respect to the legs and arms. And there was no statistically significant correlation between the BMI of the patient and the corresponding REBA scores. So we have been talking so much about posture. What is posture? Posture is the spatial arrangements of body parts as they align to perform a task. It is influenced by the task itself, the work environment, and the biological characteristics of the worker. So the measurement and assessment of posture has been an important topic of interest for ergonomists, and that was the topic of this study also. So in this study, we found that there is an 80% risk for bariatric surgeons to develop musculoskeletal injuries. Though the literature available on this is limited, whatever literature we could find also showed a similar picture. This study, which was done on the prevalence of musculoskeletal injuries in bariatric surgeons, showed that around 66% of the surgeons had developed musculoskeletal injuries and developed discomfort as a result of performing bariatric surgery. And around 27.2% of the surgeons had to decrease the number of surgeries they performed as a result. This study, which was done on postural ergonomics during robotic and gastric bypass, showed that most of the surgeons had a deviation from the ergonomically correct postures with respect to the upper arms and the wrists. This was a study which was done on simulated models, which showed that working on obese models was more difficult than working on normal BMI models. And this study, which compared the French position versus the American position, showed that working in the French position was more difficult than working in the American position with respect to the ergonomics aspect.
You have to conclude because 30 seconds left, because we have another presentation at 5 o'clock.
The limitations of this study are the small sample size, and also we assess the postures by, we assess the ergonomics by capturing photos during the surgery. A continuous real-time assessment would have been a more accurate analysis. In conclusion, we can say that most bariatric surgeons face a medium ergonomic risks, and further action is required by the surgeons to alleviate the symptoms and prevent musculoskeletal disorders. So further studies are required in this aspect, and bariatric ergonomic protocols need to be set up to prevent musculoskeletal injuries. Thank you.
Thank you very much. I think we have to go to the last speaker because there is a session immediately after.
Okay.
Thank you for your presentation. I think it's a very important topic.
Thank you.
The last speaker will be from the UK. Monad Garba will speak about safety of new bariatric service in a district general hospital, preliminary results. I'm really sorry to say, but we have only 6 minutes left. The session is
I'll try to make it short as much as I can. So thank you so much, Mr. Chairman, and the moderators to allow me to present my presentation. And, no, it's Mohanad Gaber. It's the last presentation, please. So, just to highlight, Kingston Hospital is a district general hospital at southwest London, where I moved 3.5 years just before the COVID time, after practicing for 10 years back home in Egypt.
We need the last presentation, please.
Can I have the last presentation? So we're aiming in this presentation just to show how we can initiate a service within a district general hospital and make it safe in a partnership with a more senior and a tertiary center, and progressing from being just a service provider for the tertiary center, moving to be independent, and that's the future plan within the next few months, to be totally independent center to perform bariatric surgery.
Is it possible to have the slides?
Okay, I can start. Hopefully, I can remember my presentation.
So
as we know, it's the magnitude of the bariatric problem is massive. We have more than 600 million population all over the world labeled as obesity, and in terms of we check the OECD, yes, I've got it now, and I have no conflict to show up. And moving on, as we know, the magnitude in the Western world as well is massive, and we have the OECD data 2021 that's showing we have measured weight as overweight or obese population, especially like in UK, we have more than 64% of the population labeled as overweight/obese. And given that, we thought about offering our help at Kingston Hospital to the tertiary center to help limit the waiting time for our patient, which reaches about like 3 years at the moment at UK with a limited capacity. We're doing in UK like more than 5,000 cases only per year all over UK, the 4 nations. So to initiate a service, we need to have human resources, we have physical resources, and as well the leadership and management. So for the human resources, we're talking about our nurses, our doctors, and all the allied health practitioners helping us within the service, and all need to have a previous training within a bariatric center, and especially if we talk about the surgical perspective, indeed we need to have our surgeons having a previous bariatric surgery, which was part of the process when they initiated the process when 2 consultant surgeons were recruited in 2017 and joined Kingston Hospital, initiating a new service. And as well to check the physical resources in terms of you having everything within the hospital that can fit with bariatric patients, like your equipment in terms of your tables, theater tables, your stacks, and then moving to the wards, the beds, the doors, and everything needs to be checked before you start your service, because you are dealing with a vulnerable group as well as a very precious patient with special needs. And as well, at the end, you need to have a leadership and management and support from your management to go on with your business plan, which should be a good business plan to allow for the business to flourish. And in terms of Kingston Hospital performance, we're doing very well with our patients and population, and even we were recognized by the Royal College of Surgeons. We have a national project to improve the service for the acute laparoscopic cholecystectomy for acute cholecystitis patients, and Kingston Hospital was ranked second on whole the nation within this project. And as we know, given the magnitude of the problem of the obesity, loads of our patients were already obese patients. So dealing with an acute setting with obese patients, we were doing very great, and we had a good outcome for our patients. And this was quite encouraging to improve and support our plan to proceed. So it was a very detailed and thorough preparation that started before the COVID time, few years, and because of the COVID, everything was stopped and took a long time to reinitiate the process again from the start till we got to the big day. We started our first list in July 2021. This briefly how it looks, my original city where I was trained and born, and then moving to UK. And now going to the presentation where phase 1, which we are reporting at this presentation at the moment, it was a 6-month time interval, which the agreement was to have a single list every month with patients coming from the tertiary center, which is St. George's Hospital, with surgeons coming from St. George's Hospital with the support of our local surgeons, and everything is provided through our hospital. So we had 3 surgeons, 6 lists over 6 months, and we operated on 15 patients, and all of them were females. And the selection criteria were quite strict at the start, because you don't want to have any kind of deviation within your practice and make it as safe as it could be. So we had an age group of average age of 40 years with a BMI of average 43, and the ASA grading, we had 40% of our patients were grade 2 and 60% were grade 3. none of our patients had diabetes at all or obstructive sleep apnea. We had 5 patients with hypertension, 6 patients with GORD, and we had only like 3 patients with mild psychological disorders. In terms of the procedures, we had the procedures were performed only laparoscopic sleeve gastrectomy and Roux-en-Y gastric bypass.
1 minute.
1 minute, finishing. And one case was abandoned. It was the first list. It was a big liver, and it was deemed unsafe to proceed, and we want to make it as safe as we can do. And post-operative stay, it's only 1 to 3 days, with a 1.5 days only, and no immediate post-operative complications. So we have managed to say that Kingston Hospital has managed to provide a safe service for the patients initially, and phase 2 was in indulging the local team as surgical, because the anesthetists were doing from their side, no problems, and the surgeons were involved at this point locally to be doing steps of the procedure to be signed off for the procedure. And the next phase is going to be in hopefully January 2024 to start our service independently and to have our own local patients. So hopefully, wish good luck for us for the next step. And that's it.
Thank you very much. We have to stop here. We are already 2 minutes over time and the next session has started. You want to say some closing words?
So thank you very much again for joining us today, and also thanks Sonia and Morris for moderating this session. And I hope all of the abstract presented today can get published in the near future. And I hope to see you next year in Melbourne. Thank you. Thank you very much.